want to thank you to our very first luncheon learn. We are very excited to have Dr. Turkula, who is our new orthopedic surgeon, here presenting, and we hope you all enjoy it. And thank you for being flexible. We had a lot of interest in people hearing you talk, so you guys are a little squished, but we appreciate it.
Yeah, good. So, hi. Happy to be here. Nice to see some faces in person. Sounds good. I'm Stefan Turkula. So, yeah, as Jay said, I'm one of the new surgeons here. And I pared this talk down from like a very, very long one to a little bit more of a focused one, which I think is going to be a little bit better. So we'll talk a little bit about some management, some very common things in the ACL tears and meniscus tears. And it'll also just be a good kind of overview of just, it's the principles that we're going to talk about there, at least they'll be applicable to other joint parts as well. But rather than just like give everybody a 45-minute anatomy lecture, I thought it'd be a little bit easier just to keep it a little bit shorter. I'll talk a little bit about myself as much as I don't want to, but I will. So, happy to see everybody. So I have a tear. Does it need to be fixed? And that's a pretty common question we get in the office. Or more often it's like, I have a tear, you have to fix it. So this is a little bit of a conversation about not everything needs surgery, right? But some things do very well with surgery, and so that's part of my job is parsing that out and figuring it out with you folks as far as what's the most helpful. Hi. And so we're going to focus a little bit on the knee, but like I said, it'll be applicable to other parts of the body. Let's see. Okay, so a little bit about me. We'll just go through the biography. So I grew up in Minnesota, so a Midwest kid. I say that I was a bit of an Army brat first. I was actually born in Germany and then lived on the East Coast for a bit and then just landed in Minnesota. I skied mostly for my life. I was a competitive freestyle skier, won a national championship and some junior Olympic stuff doing that. And then I went to college and I quadruple majored in skiing, lacrosse, football, and a little bit of biology. Football ended at about 2 years because I was not going to the NFL. But I still skied, played some lacrosse. I actually tore my ACL when I was in my senior year, so I got to do the 5-year program, which was actually nice because then I got a little bit more biology. Then it's not in here. Then I went to New York City for a while, did some research on some various types of cancer out there, and then found my way into medical school at Drexel in Philadelphia, which was a great time. Stuck in the Philly area to work at Cooper University Hospital, which is probably the second busiest level one trauma center on the East Coast. It's a super busy trauma center. It covers half of the state of New Jersey, which was a great place to train. It's like, when I moved there, I think it was back to back worst places to live in the United States, which is why I lived in Philly. The distance is sort of like Victor to Driggs, but if like the Teton Creek was like the Delaware River. So it's really close. So I had a great time there, learned a ton about trauma, which is still a big part of my practice, so I still like taking care of broken bones and all that sort of stuff, and we saw the worst of the worst there. But my passion's kind of always been in sports and preserving joints and kind of, working around athletes and that sort of thing, and so I went and did a fellowship at the University of Minnesota, back where I was from, at the Tree Orthopedic Center, and I got to have some pretty cool opportunities there where I spent a year with the Minnesota Wild, who came to tonight. They're 1-0 against the Stars. I spent the season with the Twins as well, and I got to go to spring training and meet two of my childhood heroes. So that is Rod Carew and Tony Oliva. That's me. So I got to see them and make all my uncles jealous. So that was pretty cool. That was spring training, but part of that is just kind of getting to be around the professional level of athletes, which is a kind of weird world to be in, to be honest, when it comes to healthcare, because it's not like you and I. But it helped kind of open my eyes to a whole different way of taking care of people. Then I worked at the with the University of Minnesota Sports too. Then I went and took my first job out of training up close to Lake Placid, working for the University of Vermont in Plattsburgh, New York at Oswego Champlain Valley Physicians Hospital. And I was the team physician for their D3 school. Very good women's hockey, that's about it. But they were really fun to take care of. And then over the past year, I've joined the U.S. Ski Team Physician Pool, which is a group of physicians who kind of travel around with the U.S. ski team to all the different parts of the U.S. ski team to their various events and provide medical coverage when they're like in, Kazakhstan or Georgia or something like that. So that's been pretty cool. The important part is the family that I came out here with.
I'm sorry, it's a question.
Ooh, yeah.
Yeah, it's not a question. I'm wondering if you could just speak a bit.
Ooh, I can try.
Thank you.
I'm getting over a little cold, and I'm a mumbler, so I will try to speak from the diaphragm as best I can. Anyway, this is my family. We moved out here. This was actually in Italy like 6 months ago, so it's warmer. But that's my wife, my son Leaf, my daughter June, and then the important guy, this guy, who didn't come to Italy with us, so he's not in the picture, but Walter. So that's keeps me busy. Yeah, so I guess back to the thing we're here to talk about. So I have a tear. Does it need to be fixed? And a fantastic mentor of mine once told me, anything in medicine, if somebody asks you a question and you don't know the answer is it depends. Because there's no absolutes. So it certainly does depend on a lot of factors, and we'll talk a little bit about that. So, like I said, we'll talk mostly about some ACL tears, then some meniscus tears. So in terms of if you injure your ACL or you tear your ACL, these are our main treatment decisions, right? Do we repair it? Do we reconstruct it, build you a new one? Or can you just live without it? We'll talk about that. So a little bit of the basic anatomy here. The ACL is one of the primary stabilizing ligaments in the knee. It generally limits the shin bone, the tibia, from sliding forward on the femur bone and rotating. And it's the main restraint for that. And because of that, it gets injured quite frequently because we as humans like to run around on our legs and put our legs in weird positions. And so it tends to be injured in sort of a twisting, sometimes a hyperextension thing, often in non-contact sports. Probably the most predominant sport is adolescent women's soccer because they're running, cutting, pivoting. And it's that cutting, pivoting, quick deceleration from running that really puts a lot of force through your knee. And if you're not at the right position, it'll just go. The ligament just gives out. Also, obviously common with more collisions and contacts like football, car accidents. I consider there's different falls in skiing. I'm sure there's plenty of people here that ski that, sometimes you just catch an edge and you fall over. Probably can't call that a collision, but sometimes you're going 60 miles an hour and you tumble like halfway down a mountain. That I equate more to like a contact injury because it's pretty violent. And these are common injuries, more than 200,000 a year, which is why they get so much attention, and they're very common. And they get a lot of attention, too, because athletes that we like to watch for entertainment essentially need it for their jobs. So they get a lot of attention in the media as well. So if we injure it, the main symptoms you're going to get are going to be some swelling. Your knee will swell up because there is a little blood vessel that lives inside the ligament, and that gets torn too, and then your knee just starts filling up with blood. And it will be pretty swollen for a period of time. Maybe not right away, but certainly over the next day or two, it'll blow up like a balloon, and you'll start losing some motion. It certainly hurts. Sometimes you can't walk on it. Sometimes you can. I injured my ACL. I skied back down out of the backcountry, and I was like, I thought, I tweaked something. But then I got out of the car once I got home, and I couldn't move my leg. And I was like, this is much worse than I had anticipated. And lo and behold, that's what happened. So you start losing some motion as that swelling comes in. And then the swelling will start to go away. You'll get some more normal motion back. And sometimes your knee can feel almost normal. And that's because you don't need your ACL for most things in life. You don't need it for walking. You don't need it for riding a bike. You probably don't need it for even just running in a straight line. But it's those twisting, cutting, pivoting things where if you do tear your ACL and you're walking and you go to turn and your knee gives out, that's when you need your ACL. And so we diagnose these injuries with a physical exam. Obviously, we'll look at you and push and pull on your knee. We take some x-rays to make sure nothing else happened. There's also some signs on x-rays that we can see that will help us determine if it is actually probably the ligament. And an MRI seems to be the mainstay here. An MRI is a really good study to look at all this stuff, to look at the ligament itself, and other things that are commonly injured with ACLs, particularly these things here called your meniscus, which we'll talk about next, these little shock absorbing discs that can get stressed and stretched. Because when you tear your ACL, the next things that are taking a lot of that force is the meniscus. They kind of work like a doorstop. And an analogy I use is your ACL is kind of like the deadbolt in the door to stop it from opening. And if you get rid of that deadbolt and there's just a doorstop there, that starts taking the force next. And it's not as good, and it can wear out over time. So that's kind of where the meniscus plays in terms of getting injured with these also. So when we're making our decisions here, these are kind of generally the main things that we're going to be worried about in terms of what we do for an ACL injury. Age is a big part because younger folks tend to be more active and have a little bit more demands on their body. Maybe they're still playing sports. Activity level is probably for me the most important thing, and the combination of these two, age, activity level, and overall health, gives me more of a physiologic age. Not necessarily just your age as a number. And if I haven't noticed anything in my few weeks in this valley, is a 60-year-old here is probably a 40-year-old in New York. The general activity level, overall health is higher. People have a bit more demands. People move out here because they're like, I'm just gonna ski, I'm gonna hike, I'm gonna run. And if that's your lifestyle, that's my goal, is to get you back to doing that as best you can and as safely as you can. So I would say 20 years ago, if I ever told somebody I was going to do an ACL reconstruction in a 50-year-old, I would go to jail. Probably not jail, but people would raise their eyebrows and say, what? Just put a total knee in them or let them live. But what we've learned is that if the rest of the knee is healthy and physiologically you're otherwise healthy, why would I not treat you like somebody 10 years younger, 15 years younger, if they have the same knee and we can prevent you from going down to get a knee replacement, which is a big surgery too. Probably the argument there would be we do have a lesser ability to heal as we age. That's just life. We all feel it. We're not 15 and you don't heal like you're 15 anymore. And so going through any surgery can take a little bit longer to heal, particularly ACLs, because you're asking a ligament to heal rather than just bones to heal, and they heal a little bit slower and they're a little bit more finicky. So the recovery is long. So before I get into all that, we'll talk about the rest of the stuff. So another big question is arthritis. So if you already have arthritis in your knee and you tear your ACL, the cat's sort of out of the bag. At that point, there's no point in putting a new ACL in because you're just going to have a painful knee from the arthritis anyways. So then we usually have more of a frank discussion about maybe trying a brace or trying things that aren't surgery and maybe teeing you up for a knee replacement down the road, because you can get stability from a knee replacement and you also get the pain relief. So those are the things we look at when we're looking at these MRIs and x-rays and things when you have injuries like these. And also timing, if you just injured this thing 2 weeks ago, that sort of changes our decision making than if you're it was back in '94, I had a little bit of a fall, I never saw anybody about it. And you come in and it's all right, well, that sort of changes our mindset a little bit, how we're gonna treat it. So, and also concurrent injuries. I talked a little bit about meniscus tears, or if there's other ligaments injured, all that stuff, or broken bones, all that stuff plays into how we decide what we're going to do. The non-surgical management of ACLs gets not as much attention as I think it should, because it historically has been a very great way to treat these. And John Elway and Hines Ward both played their entire NFL careers without an ACL in their left knees. It's pretty wild, right? It's also super rare. So those guys, for whatever reason, were built in a way that they didn't necessarily need their ACL, and some people are. Sometimes just the anatomy of your knee itself is built in a way where you don't need that ACL to stop your shin bone from sliding forward, because maybe your bones are built in a little more congruent way, or you have some different slope of certain things, and you don't need that ligament. And so some people can do very well without surgery, is my point there. But if we come to the decision hey, maybe let's try not surgery, we make sure that we get your pain under control from when you do hurt it. physical therapy is super helpful because when your knee hurts, you don't want to move it and your muscles get weak. Your muscles also can help protect your knee itself from the force. Your muscles are sort of shock absorbers also. So if you have stronger muscles around your knee can feel a bit better because it holds it in a better position, and they can take some of the force away from the areas that feel the pain, which are the ends of the bones lined by this super smooth articular cartilage that we care so much about. And like I said, it can be very successful. When this doesn't work is those times when people have persistent instability. So instability is not necessarily something that I will find. I find laxity. I tell you, yeah, this seems loose in the clinic. Instability to me is something that you folks would tell me. But a patient comes in and they're like, I don't trust my knee. It gives out on me like every week. I don't know when it's going to happen. And if I know you have an ACL tear at that point, that's when I'm starting to think, okay, that's like pretty persistent, like chronic instability, even if we tried to do this without surgery. And what we know is that if we continue down that road of not surgery, they don't do as well if you have that persistent instability for all the reasons I just talked about, because you don't trust it, you don't want to use it very much, and people don't do well. This is from a study a few years ago that looked at chronic ACL injuries in people with persistent instability, which is what I just talked about. And if you did surgery, which is the blue line, obviously you have that early not doing so hot because somebody just cut you open and plunked some big hunk of tissue in your knee. So you got to recover from surgery, but then you end up doing probably the best. If you started out just doing rehab, no surgery, you start out doing great. Then you start to fall off a little bit. And that has a lot to do with that persistent instability, not trusting it, things just not feeling great. And then this line is folks that tried rehab, didn't do very well, then they're like, you know what, give me surgery. They end up closer to people that had surgery immediately. So that's the time when we abandon the non-operative management. If everything else in your knee looks good and we're trying to get you by without surgery, you may be better off with surgery, is what these sort of studies tell us. And that's just an important thing, I think, that we've learned over the years.
Can I ask, is that just a simple ACL tear? Just no meniscus, no
Correct.
cruciate, no.
Yeah, that I don't know the specifics of the inclusion criteria of that study. Meaning, if they said you can't have a meniscus tear, you can't have anything else. But in general, yes, because the ACL seems to be what drives most of the symptoms. And if you have an ACL tear that doesn't get treated in some way, and you have persistent instability, your meniscus is that doorstop that's now getting banged into every time your shin bone tries to move, and you get these really degenerative tears of your medial meniscus on the inside part of your knee, and that can start causing a lot of pain and arthritis and stuff like that. That's a common scenario. So surgery. So there's a few decisions that we make for surgery. The first part is about the same as non-surgery. You still got to get your pain under control. You also need to get your knee moving some before we go in and do surgery, because you have this big inflammatory cascade when you get hurt. Everything hurts, it swells, the tissues are really irritated, the lining of the joint is irritated. So if we go in like 2 days after you get hurt and do surgery, you're just poking the bear. You know, things are just going to get really irritated, swollen, and you have a really high chance of getting stiff and not getting all your motion back. Because of that, we get people started in sort of either physical therapy or some home exercises that we call prehab, just to work on getting your motion back and restoring your ability to like control your quad muscle, because that goes to sleep and goes away after surgery because we shut you down a bit. So that's important when we're looking at surgery. Obviously, bring your swelling down like I talked about. And then there's some decisions to be made about repairing your ACL or reconstructing it. So there's much more rarely are you able to actually repair the ACL. And there's very specific places that it tears. Let's see, do I have a, I don't know, let's use my finger. There's very specific places that it will tear that we know we can repair it. Primarily if it just pulls off the bone from the femur side, then we can put some sutures through it and dunk it in, save your anatomy as best we can. and repair the tendon. Or if it pulls off the shin bone side, commonly that happens in kids and it pulls off a little piece of bone with it, we can repair that back down. But if it tears in the middle, we can't really sew that together and have it healed. The reason being is it's inside your knee joint, and your knee joint is constantly making fluid to help lubricate it. That fluid is washing away all the stuff that's trying to make it heal if you sew it together. So it just doesn't heal. Because of that, the vast majority of ACL injuries get reconstructed. So reconstruction just means we take some tissue either from yourself or from a cadaver donor and rebuild you an ACL. So we just drill some tunnels in there and build you a new one. And then we wait for that thing to heal in, and that can take some time. We'll talk about that in a second. When we're starting to talk about surgery for ACLs, we talk a lot about graft choice. That's an important thing. Just as much as doing surgery on the right person, it's probably using the right type of stuff for surgery. And these are the main areas that we tend to take tissue from. So autograft is using your own tissue. Allograft is using a cadaver tissue. The difference between autograft and allograft as we get a little bit older isn't quite as dramatic. Using your own tissue heals a little bit faster, seems to heal with a little bit better tension. In general, it's a better option if you're very active to use your own tissue. If your goal is just to go for walks, maybe go skiing once or twice a year, ride your bike, but all that's been hampered by your ACL injury, then an allograft might be fine because it's a little bit quicker surgery. You don't have to heal up the area that we take tissue from, and it does just fine. The advantage of using your own tissue, though, is it heals in a little bit more reliably and a little bit stronger. And the main places that we look to take it from are three. The patellar tendon here, we take a little block of bone from your kneecap, block of bone from your shin bone, and the strip of tendon in the middle. That's the gold standard when it comes to ACL grafts. That was the original one that was studied the most in the 80s and 90s and did very, very well. And every other place we take tissue from, we compare to this. But the downside of this, and why we start looking at all these other places, is this can be a little bit painful. Because you can get certainly some pain from kneeling on the front of your knee. And the incision itself goes through some nerves, and you can get a bit of a numb patch on the front of your knee. And a lot of folks don't love that. So what we call that morbidity. So it's a little bit more, has a few more side effects when you take that graft than, say, taking your hamstrings or taking your quadriceps tendon. But I will tell you that probably 90% of the guys in the NFL, if they tear their ACL, they're going to get a patellar tendon graft. The other graft, we used to do it to a lot of hamstrings. These have sort of fallen out of favor as we've started using the quad tendon. We don't use it much with the bone block anymore. We just take the tendon itself, and it's a really thick piece of tendon, and it's great. And the properties of it are really nice. And we're able to use that pretty well, and you don't have that pain from kneeling. You don't have a big incision. It's just a tiny little incision like that. We take a strip of tendon. So that's become my go-to for most folks, in addition to the patellar tendon. So those are some decisions you make. And then we decide to do some kind of surgery, and we reconstruct it, like I said, by drilling some sockets and just passing the thing in there and getting the heel into place. Then comes the hard part. So recovery and rehab is a very hard part of ACL reconstruction. The 6 to 9 months until you return to full activity is real. People are like, I'll be running around at 3 months. I'm not going to let you do that, and I don't want you to do that, and you probably don't want to do that because most ACLs that fail surgery fail in the first 3 months. The reason being is it takes your body to take that tendon or cadaver tissue to turn that into a ligament. It takes 10 to 12 weeks. It takes about 6 weeks for it to be starting to heal in, and it actually goes through a period where it's a little bit weaker. Put it in, it's really strong, gets a little bit weak because your body's turning it into a ligament, and then it starts to get strong, and then ultimately it ends up stronger than your normal ACL. But it just takes time. It takes 10 to 12 weeks. And that is the hard part of ACL surgery. So once we get you through that first few months where you're just kind of letting you walk around on it and move it as much as you can, and get your motion back, start trying to preserve some strength in your leg, then you start running around 3 months, like running in a straight line, like very controlled. And then you slowly increase your activities. Most of us are returning to things that we want to do around 6 months. If somebody wants to get back to like a really competitive sport like soccer, football, something that's a high risk activity, then we wait to about 8 or 9 months, and you decrease people that re-injure their ACLs by 50% if you just wait that extra couple of months. So even though you're strong, you probably don't have the coordination, the proprioception, like the balance, like the sport-specific stuff that you need to protect yourself until about 8 to 9 months. And we usually do some testing with the physical therapist and that sort of thing to make sure you're where you need to be. So it's a long process, you know. And that's a lot that we try to consider when we're talking about doing some kind of surgery for you if you have an ACL injury. And sometimes when we're like, you know what, if you don't want to go through that, we can give you a brace, we can do this non-operative routine, see how it goes. And some people do very well, like I said, with that. But long term, if you're a very active person and otherwise you have a healthy knee, having your ACL reconstructed is probably the best move. Yeah. Oh, let me go back. This is just a little, this is the sheet that I actually send for ACL reconstructions to physical therapists, just to give you an idea of like how extensive the rehab is. And it's all in phases. And if you probably can't read any of that, but it goes all the way out to 24 plus weeks. So that's like 6+ months. Trying to get you back to your sport as best we can. So the physical therapy part is, like I tell everybody that I operate on, pretty much everything, but certainly ACLs, is like, my job's easy. It takes me about an hour and a half to do the whole surgery, and we're done. I'm done. It takes you like 6 to 9 months. You do the hard work, right? I guide you through it, but that's on you, right? Like, we do our best, but it's a lot of work. And in general, people do very well, you know, because people are invested in these sorts of things, and it's a very successful surgery because of that. Yeah.
You made the comment that after all the healing, that usually ends up being stronger.
Mm-hmm.
Does that also go if it's an avulsion?
No, because then you're probably still keeping your normal ACL,
Okay.
so then it's just the same,
That's
right?
okay.
But then you get the bone to heal. So
Okay.
your recovery can be a little bit quicker for the repairs, which is why some people really like them. And you maintain your anatomy and all that sort of stuff,
Okay.
if that makes sense.
Yep. Thank you.
Okay, so, see, I knew I'd just talk a lot, and this is why I made it shorter. So we'll talk about meniscus repairs. I was originally going to talk about like a bunch of shoulder stuff too, and we'd be here till the end of the day. Anyway, meniscus tears. Probably one of the most common things that any orthopedic surgeon sees in their office. They're just a very common thing. And we have some of the same questions about meniscus tears, like what do we do with them, right? So do we fix them? Do we take part of it out? Do we just leave it alone? And that sort of depends on quite a few things. So the meniscus, I always like to say it went from vestigial to vital because, 50 years ago, we really didn't know. We had an idea of what the function of the meniscus was. Some people thought it was this vestigial part left over from our development that was just there, this like piece of gristle. So you usually got injured and people just chop it out, be like, get that thing out of there, it's like an appendix. Then everybody got arthritis. So then we're like, okay, maybe it does do something. And it absolutely does. So the meniscus is this like distinct cartilage disc. You have two in each knee, a medial one and a lateral one, and they really help disperse the forces in the knee and protect that super smooth articular cartilage that we care so much about. So you're not only walking on the cartilage, the meniscus helps disperse the forces. Kind of works like a washer or a gasket in that sense, and it is pretty critical. And I talked a little bit how it also adds a little bit of stability to the knee. These things get hurt because as your knee bends, I don't have a good picture of it, it doesn't just pivot. It kind of rolls and pivots and slides a little bit. It's a kind of interesting piece of kinematics. And as it rolls back on the shin bone, it can pinch the meniscus a little bit. So people will often injure their meniscus if they're squatting or sudden twisting, pivoting, that sort of thing with a bent knee. that can certainly pinch that meniscus and tear it. Additionally, they can tear just from degenerating over the years. And another analogy I use for this is just like we were 15 and our skin looked super stretchy and thin, like we could do anything. We get older, we get a little bit wrinkly, our skin isn't as stretchy. Some of the same stuff happens in the meniscus. It's not quite as robust a tissue, and it starts to degenerate and can kind of fall apart, you know. And that happens over time. And so, but those tears can certainly be symptomatic. And so we make, and then and oftentimes you also get meniscus tears if you already have arthritis in your knee. So if you imagine driving your car across a gravelly pothole road, if that's your knee and your meniscus is the tire, you're going to wear that tire out pretty quick. And it's sort of a side effect of having a lot of arthritis in your knee. So it's sort of, you know, they go together like apple pie and ice cream. Because when you get arthritis, you get meniscus tears. They just kind of go together. So the meniscus. So we'll talk a little bit about what these tears look like. And this was, I thought, a good illustration at least. And what they look like really helps us to determine what we're going to be able to do for you. So there's all these different types of tears. One of the big bad ones that we worry about are these things called bucket handle tears. It's like a bucket handle where it rips out the whole inside part of your meniscus and it flips over. Oftentimes that gets stuck somewhere in your knee and you can't get it straight. When that's the case, we got to do something about it. Either trim it out or fix it. But those big tears tend to need something to done because you can't move your knee. All these other tears, we can always hem and haw and talk about. The location of the tear tends to be pretty important, and there's another slide coming up that shows why, and it's about the blood supply of the meniscus and how it will heal. But you know, these on the outside tend to heal very well. These on the inside tend not to heal well. So these sorts of ones are the ones that we tend to trim out a little bit, and the ones on the outside we tend to fix if we can. That said, I'm of the camp that preserves as much meniscus as I can. If it's something that can get fixed, we fix it. To protect that shock absorber disc portion of your knee, that helps protect the cartilage. And we know that long term, even though it's a little bit longer recovery, it's probably better off. Your knee is better off with a meniscus repair if it can be fixed than with having it trimmed out. These other things look probably a little familiar. It's pretty common for any joint in the body that we look at when we talk about what we're going to do is, what does your injury actually look like? What are your symptoms? Again, activity level, age, timing, your overall health. Like maybe you just had like 6 heart attacks in the past year. We probably don't want to operate on you because it's just a bit risk, so we'll just kind of treat you without surgery. It's facetious, but these things happen. And people are like, I need surgery. And I'm like, probably a little bit too risky. You know, sometimes we wait a little bit longer and your heart gets healthier and then we can. But these things are all things that we consider. And then again, if you have arthritis, that limits our ability to change your outcomes. If you have full thickness cartilage loss, meaning you've lost that smooth stuff down to the level of the bone, and you have a meniscus tear, there was a great study from England back in the 2010, 2015-ish time that looked at all these folks, and everybody did the same, whether they got surgery or not. If you had pre-existing arthritis and a meniscus tear, and you had surgery, or you had pre-existing arthritis and a meniscus tear and no surgery, at 1 year everybody was the exact same. So because of that, we've kind of backed off on doing a lot of meniscus surgery in people with arthritis. It used to be the most common thing we did. And then some smart people were like, should we do this? Probably not all the time, but sometimes we do need to do it. So those are all things we consider. As I mentioned, arthritis is a big decision maker for what we do with your meniscus. So if we're not gonna fix it, we kind of go down that same route of just taking care of your symptoms as best we can, whether or not that's with physical therapy to make your knee a little bit stronger, some injections. Just modifying your activities for a little bit, taking some anti-inflammatory medication, just to get you moving, get the thing to kind of calm down. That's a good way to go when we're not doing surgery. surgery, when we talk about that, it's usually these three options. If we can repair it, we repair it. If we can't repair it and it's an area that won't heal and it's a small tear, we can just trim some of it out. If you're young, super active, and you have a huge tear that can't be fixed and the whole thing gets torn out, we can give you a new meniscus also. We can take an entire meniscus from a cadaver and transplant it into a knee. And that does very well.
What do I got? Plastic, right?
Yours is all me, yep.
Yeah, plastic.
You got some metal and plastic in there?
I don't know
Good.
what I have in there, but it all works.
Yeah. So when we do fix them, it looks pretty similar to this. We go and just place some stitches to hold the thing together. And the decision, and this is what a meniscus transplant looks like. You take a whole meniscus and sew it in and put a couple bone plugs in there. You get a whole brand new meniscus.
How long have you been doing that?
The meniscus transplants, they've been pretty popular. I don't know that you could ever say they're pretty popular, but they've been gaining attention since probably the past 15 years. The past 10 years, they've been very popular as we've learned about the protective aspects of the meniscus, particularly if you have another like pothole cartilage lesion that we can fix. So there are other cartilage lesions, I didn't talk about it here, that we can fix some cartilage. And if you have a deficient meniscus, you can give you a new one. So they've been very popular for that sort of thing. Yeah, I would say the idea of a meniscus transplant has been around for a while. Has been quite popular for the past 10 years.
Quick question.
Yeah.
So I have arthritis in a knee and suspected meniscus tear. Does an MRI show the extent of the meniscus tear, or would you recommend doing a scope, exploratory scope, just to get a full reading on what's going on?
The MRI is helpful for a couple of reasons. First, the X-ray is helpful to show us how bad any arthritis would be. If you still have some space between the bones and it's not totally gone, and we could see that on the MRI too, then we look closer at the meniscus and what the tear looks like and that sort of thing. Based on your symptoms and what we see in all the imaging, then we decide, all right, is it worth going in, putting the camera in the knee, looking around, seeing if there's something we need to take care of, or is this something that looks like it may just burn itself out, and you just got to kind of wait that period of time and it'll get better. So the MRI absolutely would be the first move.
And if that wasn't conclusive, is it a good idea to do a quick scope? And
Not always. Sometimes it's helpful. It is not always a great idea because it's still surgery, And I am sort of the mindset that if I'm doing surgery, I want a pretty specific reason to be doing that surgery, to put you through the anesthesia, the risk of like bleeding, infection, stiffness, pain, all the stuff that can happen during surgery and the recovery, Just cleaning up your meniscus, we talk about it here, it's not like you run out of the hospital that same day. You're still on crutches for a little while, it's sore. I'm sure people in here have had that procedure. It takes you about a month to get back to doing things you want to do, even if we just go poke around and look at it. So it really depends. That's my answer for everything, is it depends. So it depends on what the MRI looks like, what your exam looks like. Sometimes, I'd be like, what, I don't see it on the MRI. Your knee really does examine like a tear. I think, let's go look at it, make sure we're not missing something. That's occasionally something that we do, but not very commonly. Mostly because MRIs are good enough these days to show us most things that we need to see. Okay. Excuse me. So we just talked a little bit about this. So the recovery from these things is vastly different. So if you trim it out, like I said, you start walking on it as much as you can, using it, getting your motion back until it feels good. It takes about a month, is what I tell most folks. If you repair it, then we got to protect our repair. We can't let you just start running around on this thing and we put a bunch of sutures in because you're just going to pull it apart. So we got to protect that repair. So you're usually non-weight bearing. Occasionally your toe touch weight bearing, depend on where the tear is. You wear a brace, you use crutches, we limit your motion a little bit to protect the meniscus, and then we get you moving a little bit longer, and it's closer to about 3 months of a recovery if we repair your meniscus in isolation. If you do a meniscus transplant, that takes a little bit longer to heal. You're looking closer to 4 to 6 months of recovery. That's all stuff that we take into account too when we do this. The hard part for most folks, if we say, hey, I think we should fix your meniscus, is you're now going to be on crutches for 6 weeks. And then people kind of raise their eyebrows and say, no, I'm not. Say, all right, well, then we're gonna trim it out. But yeah.
Excuse me, for a young athlete,
Yep.
what percentage of the meniscus do you think that you can trim out before that knee is majorly compromised?
Oh, that's hard to say. So, in general, if you can save, I would say 3/4 of the width of it. You save as much as you can, you know. Any portion that you lose is more force that goes into the knee, meaning the young athlete might not notice it, right? And it's a common thing we do if somebody's in the middle of a season and like they can't heal from a meniscus tear, and it's like if they're a pro, it's like a contract year, or they're like going to the Super Bowl. Sure, we'll trim it out, we'll get you back in a few weeks running around. But it's, you weigh the risks and the benefits, knowing that like, all right, you're going to do great for probably a few seasons, and then it's going to start to kick in where your cartilage might start to wear down. And that's not a guarantee, you know. Some people do fine with just a little trim and they do okay. In terms of the total percentage of your meniscus, how much do you need for a young athlete? I don't know that anybody could reliably give you that number. I'm sure I know for sure there's studies out there looking at taking a certain amount and how much force the cartilage sees. All we know is that any extra force is bad. Yeah. So.
But 50% would be
50,
extreme.
yeah, 50% I'd be worried.
Yeah.
You know, and the second they started getting more symptoms, then we'd probably be talking about doing something else to help. And there's a, you know, kitchen sink full of other things that we can do. Yeah. So there you go. I have a tear. Does it need to be fixed? Now all you know that it just depends. It depends on a lot of different factors. And that's my job, is to help us facilitate that conversation, kind of put options on the table for you. You know, some people are like, Doc, make the choice. And I say, well, here are your choices. You know? I really try to treat people in a way where we make the decision together, you know. Occasionally, you know, people are like, no, just tell me what to do. I'll go by the statistics and the data as best I can. But at the end of the day, it doesn't matter if I have a study of 10,000 people. You're one person in my office, and we're trying to do what's right for you. So that's where all these other things come together. And that's the hard part of the job, and it's what's fun too, because then we get to know each other and we get to chat about your goals and how I can get you back to doing everything you want to do, you know. And another line I have is, it's orthopedics, you know, we're not really saving lives, we're saving limbs and lifestyles here, but, you know, it's, for some people that is their life, you know, get you back to doing what you want to do and being happy, and that's my goal, you know, is if you come in, you're not moving well, to get you moving, to get you happy, get you back doing what you want to do as best we can.